Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody. Special guest star today, Dr. George Mandelaris. Thank you so much for being here, Dr. Mandelaris.
Yeah, you're welcome. Thanks for having me.
You've got a busy schedule, so I'm like, yes, I got him. I have so many questions that we're gonna get into this. So Dr. Reza Movahed helped me with some of the questions also. I sent him probably about 50 questions that I wanted to ask you, and he kind of tailored some of my questions also. So this is a little team effort.
Okay.
Now, I really want, and Dr. Movahed also really wants people to understand the impacts of airway issues and occlusion on periodontics and the periodontal system, and how treating the skeletal and dental components and the airway issues, we really need to take into account the periodontal system. And so we're going to talk about how our orthodontic treatments, surgical treatments, how those all interact with gums, roots, all of the system, because I think a lot of people might be confused or misled or not even think about that component. To be honest, I didn't even realize that we have to really attend to that and how important that is as I'm learning about this process and how certain patients have lost teeth due to different dental or orthodontic or airway techniques because they weren't considering those impacts or they weren't evaluating that before and during the treatment process, that it's really important to take that into account. So before we get into the depths of this, let me introduce you, Dr. Mandelaris, and all of your amazing credentials. Dr. Mandelaris attended the University of Michigan from undergraduate through dental school.
Go Blue.
Got to throw that in. He completed a postgraduate residency program at the University of Louisville School of Dentistry, where he obtained a certificate in the specialty of periodontology, as well as a Master's of Science degree in oral biology. Dr. Mandelaris is a diplomat of the American Board of Periodontology and is a fellow in the American and International College of Dentists, the Academy of Osseointegration, as well as the Pierre Fauchard Academy. Dr. Mandelaris serves as an ad hoc reviewer for the Journal of Periodontology and the International Journal of Oral and Maxillofacial Implants. In 2021, he was appointed as an editorial consultant to the International Journal of Periodontics and Restorative Dentistry. He has published over 40 scientific papers in peer-reviewed journals and has authored 14 chapters in 10 different textbooks used worldwide on subjects related to computer-guided implantology, CT/CBCT diagnosis, and surgically facilitated orthodontic therapy, SFOT. In 2023, he authored and edited the book Surgically Facilitated Orthodontic Therapy, an Interdisciplinary Approach, one of the first textbooks of its kind in the profession. Dr. Mandelaris is a two-time recipient of the American Academy of Periodontology's Clinical Research Award, an award which is given to the most outstanding scientific article with direct clinical relevance in periodontics. A nationally recognized expert, he was appointed by the AAP to co-chair the 2017 Best Evidence Consensus Workshop on the use of CBCT imaging in periodontics, as well as co-authored the Academy's guidelines. And in 2018, you were recognized with American Academy of Periodontology's Special Citation Award. There's so much here. I didn't realize how much I got off of your bio. Look at this. Dr. Mandelaris, you currently serve on the American Academy of Periodontology Board of Trustees. In 2018, you're the recipient of a Memorial Award for Clinical Excellence in Diagnosis and Treatment Planning. You're a key opinion leader for several industry leaders, and you hold memberships in many professional organizations. In your private practice at Periodontal Medicine and Surgical Specialist is in Glenview and Oak Brook Terrace, Illinois. You limit your practice to periodontology, dental implant surgery, bone reconstruction, and tissue engineering surgery.
It's all past performance. So you got to be good today.
Wow, you got to live up to this reputation. Look what you've done for yourself.
I think Rez is setting me up for something.
Yeah, you're standing on the shoulder of your own.
Yeah.
Oh my God. This is so really, I always think it's important to read people's bios and to say all of this, because look at who we are talking to. I am talking to an expert in periodontics and a leader in the field. I just feel so blown away by being able to ask you these questions that have been festering in my mind now for a while. So let's get right into this. First of all, I'm always curious, how did you decide to become a periodontist? How did that land for you?
This is a long story. I have had an incredible journey with a lot of mentors throughout the way, and basically starting very early, knowing about my grandfather. I never met him, but my grandfather was a physician from Athens, from Greece. Came over here very early in the 1920s and 30s. He basically went to medical school at the University of Athens and took the boards over here, and without really having an American education, but was able to pass all the exams. He was an OBGYN at the time, and I always thought I wanted to follow his footsteps. But I had a neighbor that I grew up with whose dad was an orthodontist, and I thought, oh, this looks like a pretty cool profession. He does pretty well. And so I'm taking all the same classes, and I was able to get into dental school a little bit early. So I thought it was a good opportunity. So I happened to work for a prosthodontist who was actually the prosthodontist who started Clear Choice. And at the time when I was in college, and it was just basically trimming models and stacking shelves and doing whatever I could to learn about the profession. And I started dental school at the University of Michigan, and ended up developing some relationships with people that kind of, when you're younger and you think you know what you want to do, but you come into contact with people that are influential in your life early, and they kind of shape and mold your thoughts and perspectives and so forth. And that was very true to me. I mean, the periodontics department at Michigan, I don't know how I got wrapped into this, but they got a student research project one year, and one was an ADR project. And then some of the faculty there just took me under their wing. I did these projects with them. And then, so it was really kind of Bob O'Neill and 𝐃𝐈𝐒𝐂𝐋𝐀 Wong who really mentored me young. Lori McCauley, who's now the provost of all academic affairs at the University of Michigan, she was influential, and Martha Summerman, just really giants. I mean, Martha's gone on to be the chair of NIDCR. Lori was the chair of periodontics and the dean of the dental school, and now the provost. I guess looking back, I've been very lucky to have some mentors along the way. And then going through dental school, I really liked periodontics because it was a lot of biology coupled with surgical treatment. And I just thought it was fascinating. And that's kind of how it happened. And then I started at the University of Louisville because the program director there was somebody who had trained 𝐃𝐈𝐒𝐂𝐋𝐀, who was my mentor in dental school, and he thought this would be a great program for you to go to. It was very clinically relevant because I wanted to be a private practitioner. It was a really good leap of faith to go to the University of Louisville under the tutelage of Henry Greenwell, and unfortunately the late Henry Greenwell and the late Connie Driscoll. And it was awesome. And then after that, I ended up getting an opportunity to join Alan Rosenfeld's practice in Chicago. And Alan is very much a teacher at heart. And he was really, I think, just an amazing mentor for me as well. He was the former program director of periodontics at Northwestern University, but he had attended Penn in the heyday in the late 70s with D. Walter Cohen, Motor Amsterdam, Jay Siebert, Slick Van Arsdale, all these legendary people that basically brought perio prosthetics to what it is and to the profession, perio ortho. And then he broke away from Northwestern and was in private practice. And he was looking for somebody at the time that I was coming out of school. And I really didn't want to go back to my small town blue collar roots in Flint, Michigan. So I ended up taking a leap of faith and moved to Chicago. And it was a great move. And here I am 25 years later.
It's a great story. A recurring word I hear is mentor. And I
Yeah,
feel like it's important for all of us to
yeah,
really recognize and remember our mentors and who took us under their wing and really changed the outcome of our lives, of our career. And sometimes those mentors don't even know that they did that,
yeah.
right? Even in young childhood, we've had people that have influenced our lives and our pathway, and they might not even know.
Had I not had certain people come into my life, I don't think there's any way I'd be where I'm at today. I mean, certainly starting with professionally, starting with Alan, kind of giving me my first opportunity in private practice and helping me because he was very early on in with CT imaging in the 80s and medical grade CTs. And he was the one that kind of wrote the papers on prosthetically directed optimal final tooth position of scanning a barium template with imaging to know where to place implants based on a prosthetic position. I mean, at the time we were considered glorified hygienists. We were just basically radiating people for no reasons, these periodontists who don't know what they're doing. Because if you were a good surgeon, you just open flaps and put implants in. And Alan he was way ahead of his time. And that led to obviously guided surgery and Simplant. And obviously his role and relationship for me was huge. But then I think really the next one was probably Dan Spagnoli. I've had some oral surgeons in my life that had they not been willing to share with me and teach, I would certainly not be where I'm at. The top of the heap would be Dan. Dan is an amazing bone biologist, PhD, oral and maxillofacial surgeon extraordinaire. And he used to run the program at LSU. And he taught me tissue engineering. He taught me really more advanced reconstructive surgery. Started me thinking about looking at the patient's craniofacial dimensions. I started to see how an oral surgeon looked at the case. And then Von Urban was a very important person early on. And Rob Relly, another oral maxillofacial surgeon in Los Angeles. And certainly I would say Reza has been a very important person in my life, just embracing what he feels is important from an orthognathic standpoint as a periodontist, because there's this missing link here. Forever it's ortho-oral surgery, and it's only those two that speak the language. It's like everybody else doesn't know what decompensation means. It's like almost like speaking Greek. So, but I was able to really learn that, and I think that's an important part, because now we have the advent of imaging, we have the advent of simulation technology, and we can see the anatomic truth of what's really happening, and we can do things better today. And that's really at the heart of what my passion is, which is interdisciplinary dentistry. I just love collaborating with all the different specialists, the restorative dentists, prostheticists, the other people on the team that historically aren't people that we've kind of grown up with in dentistry, like myofunctional therapists, speech and language pathologists, thinking about those things, ENT. This has all been an amazing journey of where I think contemporary interdisciplinary dentistry is today.
Yeah. And I love that, the anatomic truth. We can see the anatomic truth. Now, this is a really good segue to my next question, because I don't know if everybody understands the differences between an oral surgeon, an oral maxillofacial surgeon, a periodontist, an endodontist, and a prosthodontist. So obviously, if you're in the field, you know that. But as a speech pathologist, I'm not as aware, and maybe other people listening don't know all those differences. So could you explain that?
Well, I think here in the United States, an oral surgeon, oral maxillofacial surgeon, that's the same thing. The title is oral and maxillofacial surgery. In Europe, interestingly, an oral surgeon is actually one who is basically doing more dental alveolar type surgeries, where they kind of break off in Europe and have a maxillofacial surgeon, which would be somebody who probably handle more like cancer care, maybe orthognathics, things like that. But here in the United States, it's oral and maxillofacial surgeon, and that is fully encompassing of head and neck surgery and etc. Third molar is jaw surgery, etc. Pathology, implants, bone grafts. As a periodontist, basically my specialty is one of the two surgical specialties of dentistry, which is periodontics and oral maxillofacial surgery. Periodontics is a little bit different than oral maxillofacial surgery, although there's a lot of interplay between the two. Our focus is on saving teeth, periodontal regeneration, but our expertise is also in bone regeneration, implant placement, peri-implant diseases today, mucogingival surgery, so soft tissue conditions, and also some pathology conditions that could be referred to as squamative gingivitis, things that are dermatological in nature that wind up in the mouth. So it's part of our repertoire as well. And SFOT is a very incredible blend of all of these things. An endodontist is a specialist who basically focuses on the treatment of the root canal system and doing perhaps some surgery related to apical surgeries and so forth. Prosthodontist is kind of a specialty in restorative dentistry who does full mouth reconstructions and implant prosthodontics. And really a specialty should be especially is restorative dentistry, because to be an exceptional restorative dentist is almost a specialty that's probably the hardest of itself, because they have to kind of rein all of us together. They're kind of the quarterback, and they got to rein all us together. From a patient care standpoint, that's kind of the quarterback. So I almost include them really as a specialist as well. But there are other specialties like oral and maxillofacial radiology, dental anesthesia now, which is an incredible specialty. It's similar, but it's distinctly different. And they're very complementary, actually. As historically, most people think of us as competition because we both do implant surgeries. But actually, it's very complementary because there's such a different skill set that we do, and we really can complement each other.
And what ages does a periodontist work with? For what various reasons? Do you mostly see adolescents and adults?
I could see little kids. I could see infants for tongue tie reasons. I have a colleague of mine, you may know Milt Gabelis. He's an exceptional periodontist here and in my neck of the woods. And he's very well versed with tongue ties and so forth. He sees infants. But I would say in my particular practice, I would see a young individual if they had probably an outlier type of situation, maybe juvenile periodontal issues or mucogingival problems, gum recession, something like that. But typically my scope would be probably as young as 12, 13, 14, something like that. And then typically young adults, more mature adults, and so forth.
Okay. And then everything that I like to talk about is airway. So, when did airway come into play in your field? Or maybe it's not a big thing in the periodontic field and it's maybe specific to those who have training and understanding. So, how did that come in for you? And how has it changed your perspective and techniques considering airway
Yeah,
and sleep breathing issues?
it is not something that's, I think, discussed in our specialty, and it's a travesty. It really should be. It should be a part of everybody's intake that they do because of the severity and really the gravity of the problem and just the pervasiveness of the problem. I mean, it's significant. And snoring is not something to laugh at anymore. It's a serious issue. I don't think in periodontics it really is something that's considered. But how I got involved, as I started doing a lot of the 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑 surgeries, even 20 years ago, we were really just looking at it from a dental alveolar standpoint, like a periodontal standpoint, getting the teeth to fit properly. We weren't thinking about the nose, the upper airway system, or anything like that. So that really changed quite a bit. I think with the advent of MARPI, that we started thinking a little bit differently because of the impact of nasal flow, nasal resistance, how we can improve those things, and that this was a very much needed complementary therapy so that the teeth could come together correctly without being tipped, without being, pulled out of the bone, essentially without a patient becoming a periodontal annuity for the rest of their lives, which is oftentimes what happens.
And we're going to talk a lot about that because I do have a lot of questions on the impacts of dental tipping on the periodontal system and the importance of that. But let me ask a couple questions before we get deep into that. I'm curious, surgically facilitated orthodontic treatment. Can you explain what that is, the history of that, how that's changed over the years, and how that's changed with the advent of MARPI?
Yeah, so that's an acronym, SFOT, for surgically facilitated orthodontic therapy. And really the core is what we call corticotomies and dental alveolar decortication. This technique was popularized in the 90s by a orthodontist periodontist brother team by the name of 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑, their last name was Wilco, and they trademarked this term called 𝐶𝐈𝐒𝐿codontics. And it was an amazing treatment, but it was all based on speed. So their slant was, hey, we do this periodontal surgery for this patient, we can get them in and out of braces 50% faster than what you could with conventional orthodontics. And they were missing the whole airway concept. They were missing the phenotype transformation as a focus of attention. It was really about speed. Well, no orthodontist is going to refer to a periodontist for move the teeth faster. That's just not in their, who would want to do that? But that is probably, that's a byproduct of the surgery, but it's one of the least reasons that we do the procedure. So the procedure basically has been around for, actually it's been around for over 100 years, if you can believe this. I found this in the Journal of Oral Surgery, 18 something at the Chicago Dental Conference, that somebody talked about the interalveolar osteotomy. I don't even know if they had an aesthetic back then, but it's gone through a lot of different historical, differences in names in the literature, the 30s, the 40s, the 50s, and then really popularized by the Wilcos. But essentially a corticotomy is a cut in the bone that you're getting into the bone marrow, and dental alveolar decortication is essentially creating like little dots around the outer aspects of the buccal and lingual aspects of the teeth to get somewhat close to the ligament. Essentially what you're trying to do is you're trying to simulate fracture healing. And by simulating fracture healing, you induce something called a regional acceleratory phenomena. Now, Nicole, this was actually discovered by a guy named Frost. His last name was Frost at Henry Ford Hospital. He was an orthopedic surgeon studying fracture healing. And when he was studying fracture healing, what he noticed is that there was this demineralization that happened within the bone matrix as a result of the fracture. And there's this cascade of inflammatory events that happen. So if you happen to have braces on somebody's teeth or aligners or something like that, and you create this injury, this purposeful injury around the teeth, these corticotomies and this dental alveolar decortication, you set up this demineralization that happens. Well, now, guess what? The teeth move much more expeditiously because they don't have the same mineral content. So they move more expeditiously, they move faster. Generally, in conjunction with that, we do some bone grafting. It's usually an allograft or cadaver bone graft. It's usually hydrated with platelet-rich fibrin, which we draw from the patient's blood. We spin it down. We add a little bit of xenograft, which is cow bone, because when that all incorporates into the patient's matrix, when a new bone functional matrix is developed in the alveolus, that helps maintain its sustainability for the long term. And so the bone doesn't just resorb. A lot of people chalk this up to like Wolff's Law, like, oh, well, you know, the bone just goes away. And there are certain techniques, at least that I use, so that doesn't happen, so that the bone is sustained and maintained under function over the long period of time. So that's kind of in a nutshell.
Is that regenerated bone weaker?
It's actually
or stronger?
So
It's
this
stronger.
demineralization phase happens for about 3 or 4 months, let's say 3 months. And that's the time when the orthodontist can really do a lot of the heavy lifting. They can move the teeth. They would see the patient every 2 weeks to change their heavy wires, or maybe they change the aligner trays every 3 days instead of every 2 weeks. So they move through this process much quicker. But at the end of this 3-month period of time, the histologic studies show that the bone actually remineralizes, and the mineral content is the same density that it was before, if not a little bit higher.
Yeah, I would almost think it might even be stronger.
Yeah,
Almost like when you get scar tissue, but we're talking about a bone.
you're exactly right. In fact, the other thing that happens is that because the teeth are oftentimes right up against cortical bone, very dense, hard, thick bone, when the teeth move through that type of bone without the surgical insult, they're at a higher risk for root resorption. So the roots can start to shrink. And now you have less surface area of the tooth root in the bone. And that can compromise the prognosis of the tooth. So this tends to negate that. And teeth that have a lot of crowding, there's a certain order of relapse that can happen. So the teeth have this rubber band effect and they want to move back to where they were. But by doing the surgery, it kind of unravels that and it negates a lot of the relapse potential that can occur as well. So reduction in root resorption and reduction in dental relapse, which is a positive thing.
Very positive. That's very important. What about with the impact of MARPI? Because that's a pretty popular technique now. Do you think it's a way to avoid orthodontic surgery? I know some people might think, oh, if I get MARPI, I'm not going to need orthodontic surgery. Or do you think many patients might not be getting the best treatment for their sleep apnea or airway issues because they're doing MARPI instead of just a full orthodontic surgery, thinking that's enough, I'm good? What are your thoughts?
You bring up some really good points, Nicole. I have to say this is an interesting question because obviously every patient is a little different. So depending on the degree of skeletal disharmony that the patient has, perhaps it's mild or maybe a little mild. You might be able to correct that with a non-surgical skeletal expansion alone. So possibly, but the greater the degree of disharmony, the more you're camouflaging the problem. Now, I do think that MARPI is a really nice way of improving nasal flow, reducing nasal resistance. I think these things need to be measured more than they probably are. We tend to take subjective intake forms and see how patients are doing or what they feel their perceived problem is, or maybe how they've improved. But we know that patients lie or they've gotten used to what their condition is and their condition isn't good. So it would be nice to have more of a objective measurement tool like 4-phase rhinomanometry, for instance, or something like that, that have some objective measurement tools to know, hey, this patient is getting better with this degree of expansion that we're doing. However, if we're just doing it for dental reasons, then that's a different story. But I do think that the MARPI could be very complementary to orthodontic surgery, because maybe it takes somebody that would otherwise need a 3-piece maxilla and now it becomes a 1-piece maxilla. Well, that's certainly more stable. That's less plates and screws and bends and things like that need to be done. It's probably less potential for relapse. And probably less morbidity for the surgeon at the table than doing a 3-piece maxilla versus a 1-piece. So I think there's some advantages to it for sure, but it's hard to paint everybody with a broad stroke because it's just so individualized. The more you know about this stuff and the more you really look at the patient from a craniofacial standpoint as your first approach of thinking about them, it's complicated. That's what's so valuable about having the interdisciplinary team and people that have the same kind of thought processes and values to look at all these things together.
It would be amazing if we could just have a round table of all these specialists for every patient case, and we all sit around and we all talk about pros and cons and what should be done, because that's like the only way. It's so complicated.
Yeah. And the problem is the more you see it, the more you know it. It's hard to you just can't unsee it.
Exactly. Dr. Rezimova had asked me to get into the topic of what happens when the crowns are brought into alignment in MARPI treatment. What happens to the roots?
Typically with MARPI, you're just expanding the skeleton, right? So you're moving the whole base, if you will, but you're moving the skeleton. After that's been done, then the teeth are going to need orthodontics to coordinate. And so if we keep the teeth really kind of tip like this, that's not a favorable way of loading the teeth. So the teeth are going to have to be brought into a more correct axial orientation. And that's the role of the orthodontist to do that. So typically it's MARPI, and then it's combined with orthodontic treatment to upright and put the right axial inclination of the root relative to the crown and relative to the lower arch in the face and the bite.
Okay. So also, what about grafting? Should that occur before or after MARPI, or is that not even a necessary consideration?
In my experience, most of the time, this would be done after MARPI. It'd probably be more of a unique situation. Perhaps the orthodontist has a ton of crowding and they want to correct all the crowding first and to some extent and then move the teeth. When you see somebody, Nicole, that has a lot of dental crowding, think to yourself, hey, there isn't enough bone to house these teeth, therefore they're all crowded. There isn't enough bone to house the roots of the teeth. And so if we just go unraveling and expanding the arches, we're going to cause the bone to resorb, we're going to cause dehiscences, fenestrations, we're going to cause the tissue to get thinner, and we're going to cause gum recession. We're going to put that patient at a higher risk for gingival recession. And I'm here to tell you the days are over for us using gingival recession as a barometer as to when to stop moving teeth. Those days are gone. Those are for the history books, as Reza would say.
What does that mean? Explain more about that.
That means that if you're just expanding somebody and moving teeth, and even though you don't see the gums receding at all, everything looks okay. Basically, we need to be paying attention to what is happening at the foundation level as we move teeth. What is the impact on the dental alveolar complex relative to tooth movement? What impact is tooth movement having on the dental alveolar complex?
And how is that identified? Do we need to look at CBCT imaging, or how does one look at that foundational level?
Ideally, you'd look at imaging, but we actually have with myself, Ashley Hoders, and she's the lead author, and Kevin Murphy and Marianne Evans. We have some papers coming out later this year in the International Journal of Periodontics and Restorative Dentistry on what we call phenotype-driven treatment planning. And at the core, basically, we're going to look at two things. One is the gingiva thick or thin, and do we have 2 millimeters of keratinized tissue width or not? So do you have enough pink hard gum tissue around the teeth? And also, when you put a probe in, can you see the probe through it or not? And that gives you some level of susceptibility, right? Because if it's very thin, or if there isn't enough keratinized tissue width and or thickness, then that patient is more predisposed to having mucogingival problems or gingival recession problems. And the more we expand the teeth, the more we create these bony problems around the teeth, the harder it is to have a good mucogingival outcome. But today, it's not just about correcting these problems after the fact. It's about, hey, let's get out in front of it and let's expand. Let's let the periodontist expand the boundary conditions for which the orthodontist can work within. We can expand those conditions for them and not accept a compromise. We can get the teeth in the best position possible for that patient's face, for their bite, for their tongue volume, for their airway, etc.
Okay, how do you do that before as opposed to after the fact? Is that the corticotomy that you were discussing, or how do you expand or increase the positivity of the mucogingival outcome prior
Yeah.
to treatment?
So one would be knowing, hey, what is the orthodontic plan here? Like how far are we moving teeth? And is there a digital simulation maybe you could provide to show not just with like, your typical gums and the crowns of the teeth showing how the teeth are moving, but I want to see what is the impact of that tooth movement on the dental alveolar complex. So do you have something that could show me with how the roots are expanding on the bone and what is the impact of that movement on the dental alveolar complex? Once we know that, then we know, okay, here's where we need to develop bone volume around the teeth for this movement to happen safely and for it to perhaps happen to an enhanced level that it could otherwise. That's probably the best way to handle it as a digital simulation. But if the orthodontist can give us some guidelines of here's where I want to kind of move the teeth, then I think we're in a position to have an intelligent conversation or collaboration on what, if any, treatment needs to be done periodontally to make sure that doesn't happen at the sacrifice of the patient's periodontal complex.
So this sounds so important for a periodontist to work with an orthodontist. Is this all orthodontic cases, or is this only adults? Does it matter in children because they may have like supple mucogingival
Yeah.
status versus an adult?
So I think it's important for both age groups. It's probably more important for adults. And the reason is because with an adult, they have a little more adaptive capacity. The bone's perhaps a little bit more plastic. They have growth on their side. But with an adult, they don't have those same benefits. So they don't have quite as much real estate that they can kind of push. So I think as an adult, it's probably more important.
Okay, I'm not going to lie, but I feel like most orthodontists who are treating adults, it doesn't seem standard of practice to be teaming up with the periodontist in the treatment planning of these orthodontic cases for adults. Maybe it's new information to me to know this. Do you feel like that's a common thing where orthodontists are working with the periodontist in their treatment planning of their adult cases? And also, are orthodontists looking at their imaging, seeing what is the status of the periodontal region when they're working with adults to help them plan the treatment?
Yeah, I work with a number of amazing orthodontists, and I know that they are always focused on airway, and I mean, the intake forms are always a part of their questionnaire, and it's always a part of their initial examination process. So these are things that they're already thinking about, and they're probably using digital simulation. And I could call them out and say, hey, is this case needs SFOT? And they may say to me, no, it doesn't. Here's the sure smile modeling. Let me show you what's going to happen. There's no impact here at all on the dental alveolar complex that's negative or deleterious that we have to get involved into this more significant surgery. And so I think the more astute the orthodontist is in using some of these more novel treatment planning modalities, and the more novel they are about looking at the airway component of the patient, nasal breathing, all these types of things. If it's an orthodontist, it's basically like, hey, let's take out let's take out 4 premolars, let's make everything really small and create a nice arch form, although you see huge negative corridors everywhere and the patient has a tongue that's incredibly scalloped. That's an orthodontist that probably needs to rethink how they're practicing. I wrote a paper with Jeff Posnick, who's probably one of the most famous oral and maxillofacial surgeons. He's incredible. He wrote the book on orthodontic surgery. And Jeff and I wrote this paper because, it was about, are we diagnosing our orthodontic patients as good as we can be? And the answer is no, we're not. Because we need to be using, not to say that everybody needs SFOT or everybody needs orthodontics. I'm not saying that. I'm just saying the orthodontist is the earliest caretaker of the patient's periodontium. So I'm going to say that again for your audience, Nicole. The orthodontist is the earliest, maybe the pediatric dentist actually, is the earliest caretaker of the patient's periodontium. And they have a responsibility to consider these airway considerations, expand the patient early when needed so they don't have blocked out canines and all these problems that come with not being mindful. But they have an opportunity to change the trajectory of a patient's life. And with that comes, if you're moving teeth, you're moving the periodontium. That is the heart and soul of the dentition, period. So hopefully I've had an impact on my community and getting people to think about these things. Like most anything, it really depends on the person and how much they want to dive into this and how much they want to learn. And it's like Dr. Spagnoli told me all these years ago, George, Stan, do I need to learn all this stuff? Do I need to do this? And he just looked at me and said, I guess it depends at what level you want to practice.
Yes,
and it was
I like
so
that.
pointed and so like cutting to me. It was like, okay, game on.
Like, how good do you want to be?
Yeah, I mean, how mediocre do you want to be, or how good do you want to get? How much do you want to, how far do you want to push yourself to
Yeah,
learn and to keep learning?
we're all in control of how good we are, right? We're all in control. And
Yeah.
the learning doesn't end. This is interesting because maybe people are saying, well, Airway, we got to just move teeth, get more space for the tongue. It doesn't matter. The tongue's not really caring. It just needs to help with breathing. But can you talk about what are the problems with gum recession and root resorption? Why does that matter? Why is that a big deal?
Well, I do think I will get back to the airway thing. I do think we have to measure people, right? Because even though maybe somebody who looks like they have an airway problem, they don't, right? They don't have a collapsible upper airway, or they don't have loop gain problem. They don't have these things. If you're not measuring, you don't know. And so we can't we're not technicians. We can't assume. We can't just do stuff. We have to be measuring and critically thinking about things and thinking about science and using our biologic principles to make good decisions based on what we know in the literature. But the problem is so much of this is so new. It's like the research hasn't caught up to really how we all want to practice today. And it won't for quite a while.
I'm wondering what are problems if you have gum recession? So let's say teeth are tipped. What kind of problems could that cause? And is that really that big of a deal?
Yeah, I mean, so, tooth hypersensitivity, right? Bone loss. So gingival recession equals bone loss. You don't have gum recession unless you have bone loss. Now, nobody died from gum recession, and a lot of people have gum recession that don't have dental hypersensitivity. But the root surface is more prone to having decay. And as we age and we lose saliva and we have all these other comorbidities, this is a susceptible characteristic to the prognosis of the dentition. And one of the things that, probably is the most meaningful thing to us as we get older in life is to enjoy a good meal with our friends and to look reasonably good, right? We don't want to look like, Austin Powers and have these, ridiculously long teeth. To the people that say, look, nobody ever died from gum recession, newsflash, we're dentists. We're not oncologists, okay? We're not emergency room physicians, okay? But your role and your responsibility is to optimize the craniofacial and the oral health system for your patient and not accept mediocrity as a standard of care. Because if it is, you need to rethink what profession that you're in and how you're serving your patients.
I did an interview with Dr. Mariana Evans, who talks about that early treatment of expansion. We're not just thinking airway, but we're thinking about the periodontal system. And like you said, early can optimize the gums, the roots, and that's really important as well. It is getting to these children early to prevent these issues as adults or to help prevent.
Yeah.
So what causes gum recession and root resorption? And then what are treatments for such issues like the gum grafting or tissue engineering? What do you do? So I guess maybe start with what would cause gum
So,
recession and root resorption.
so if a patient comes in and they have gingival recession, I'm always looking at, okay, probably the teeth have compensated to some extent. And if they have gingival recession, they have some level of bone loss. So I'm thinking, okay, how have the teeth compensated? What's their occlusion? Are there other factors that need to be considered so that whatever treatment I'm going to provide for them is going to be stable? Is their bite correct, or are their teeth in aberrant positions where whatever treatment I may do may not necessarily be stable long term because how the forces are being loaded on the teeth may be deleterious for long term maintenance, or perhaps put them at higher risk for fracture or dental wear or something like that. So there is a classification system of gingival recession. And the earlier stages are obviously very predictable with connective tissue grafting. Soft tissue grafting, another form of soft tissue grafting, is a free gingival graft. And that doesn't really aim to gain root coverage, but it aims to increase the zone of keratinized and attached gingiva. So we have two types of gum tissue in our mouth, Nicole. One is mucosa and the other is gingiva. And mucosa is like the back of your hand. It's very friable and very movable, whereas the gingiva is like the palm of your hand. It's very strong. It's bound down to bone. So if you take a Brillo pad and you scrub your palm, it doesn't hurt quite as much as it does the back of your hand. So if you can imagine, if the gum tissue is just all mucosa and a patient's brushing their teeth, it's uncomfortable. And it's also more prone to receding because it's very vascular, it's very thin, and it can get injured very easily. Whereas if we have more robust, or this like 2 millimeters of keratinized tissue and attached gingiva around the teeth, we have something that's much more robust, much more that's more stable, more comfortable for normal hygiene habits and so forth. And that would be the kind of the goal. So there's a myriad of things that we periodontists look at to determine, does this patient need grafting or not, depending on how much recession is there, how does it impact their quality of life, what's the tooth position like, are there other factors surrounding the regional anatomy that may need to be considered. When it comes to root resorption, there's external root resorption, which means the tooth root's getting shorter. Oftentimes that can happen because of orthodontic treatment, or maybe associated with orthodontic treatment, particularly if the teeth are being moved into very dense cortical bone and the tooth can get resorbed. Other forms of resorption could be this like invasive cervical resorption, where the resorption happens from the outside in, or it could happen just in the root canal of the tooth. The one that you're really talking about has to do with the tooth roots and them having this either genetic potential to resorb as a result of force being put on the teeth, and probably the environment as well that the roots are being pushed into. Doesn't happen to everybody, but those that are susceptible, it can happen to.
Okay. And why would gum grafting fail?
Well, if you have a tooth that's at an incorrect axial inclination, the tooth is really tipped out, and there's no bone on the front side of the tooth. Sometimes a tissue graft can be it may be unstable, it may be unsuccessful. But remember, if you have a dehisced root surface, so you have no bone on the entire facial aspect of the tooth, and you just put a tissue graft there, in the right patient, that could be very successful, but the healing of that is what we call a long junctional epithelium. So that's like a zipper, okay? It's just like an adhesion of the gum to the tooth root. Whereas really what we would like to have, if we had our magic wand, is we would like to have a regeneration type of response. We would like to have a nuts and bolts type of outcome, which means we'd like to build cementum, alveolar bone with an intervening periodontal ligament. That's a more sustainable and a better long-term result for the patient. So the corticotomy surgery, even though you may be looking at somebody that has very little to no gum recession around their teeth, but high vulnerability if we're going to move them, and you lift the flap and you notice these teeth are all dehisced, there's no bone on the facial aspect of the teeth. The first thing that we are doing is we're trying to gain periodontal regeneration around the facial aspect of that tooth. And then beyond that, we're trying to almost create a guided bone regeneration type of outcome to thicken the volume of the bone with which the teeth will be moved into. So it's a periodontal organ system that we're trying to construct and then augment and kind of displace, right? So that's how I think of it.
Okay. And so it also sounds like if the teeth are really compensated, you can do whatever grafting you want. But if you don't fix the compensation, that it's prone to that recession again. Is that correct?
It could be. Not a blanket yes, but it certainly could be, or it would be at higher susceptibility,
Okay.
right? Because you're not fixing the core issue.
Exactly.
You're not addressing the core problem.
That's what I was thinking.
Yeah, the patient wants to address the core problem. You generally have to correct the underlying compensation, which means orthodontics. And if it's an underlying compensation, there's probably a skeletal imbalance. Yeah. The jaws haven't quite aligned, right? So they all kind of coordinate together.
Here we go again, interdisciplinary care. Oh man, we just can't treat symptoms, right?
So, and that's where you have to have the oral surgeon. You have to have, I would say not just the oral surgeon, but you have to have the oral maxillary surgeon who is really good and understands like orthodontics, right? And you need to have the orthodontist that respects this, and the restorative dentist who can really take it home with the occlusion. And depending on the disparity of all these things, maybe the patient needs surgery, maybe they don't. Maybe they need orthodontics, maybe they don't. So it just depends on what degree of problems there are.
Yeah. Stay tuned for part 2. Believe it or not, it gets even better. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.